we'll learn about accommodation reflex. So it is a adjustment of visual apparatus to focus an image of the near objects on the retina. Meaning whenever we are seeing far objects, suddenly an image is brought in front of our eyes, very close to our eyes, then our eye need to adjust, okay, to focus this image on our retina. So that is why there are some changes which takes place in our eye or visual apparatus, which is called as accommodation reflex. So you are seeing somewhere far, suddenly something comes in front of your eyes. Now you need to focus on this nearby object. Okay, so the changes which takes place in the eye are called as accommodation reflex. So there are three changes which takes place. One is convergence of the eyeball. Another one is the constriction of pupil. The third change is the change in the anterior curvature of the lens. Actually, the anterior curvature of the lens increases. So the easier way to remember is three C's, okay? There's a convergence of eyeball, constriction of pupil, and change in the anterior curvature of the lens. Now coming on to the convergence of eyeball. So what exactly is meaning by the convergence of eyeball? Okay, so here what happens is the contraction of the medial rectors of the eyeball. So if you can see, there are the left eyeball and the right eyeball. Okay, so here we have your medial recti muscle, okay, on the medial side very close to your nose. So when this medial recti contracts, this eye rotates inwards and this eye also rotates inwards. So there is the both the eyes can see an object which has come very close to the eye. So this is called convergence of eyeball, or there's a medial rotation or internal rotation of the eyeball, and this effect is mediated by third cranial nerve. So the cause for, like, the nerve supply for the medial rectus is oculomotor nerve, which is a third cranial nerve, and the stimulation of this third cranial nerve is what causes convergence of eyeball. Another change what we see is constriction of pupil. This is because of the pupil constriction is dependent upon sphincter pupillae muscle. Okay. Again, we all know the third cranial nerve, oculomotor nerve, supplies the sphincter pupillae. That is why again this also goes for contraction. Clear? So the convergence of eyeball and constriction of pupil both are happening because of the stimulation of the third cranial nerve. The third change is there's a change in the curvature of the lens, nothing but there is a increase in the anterior curvature of the lens. Okay, now we'll just see the anatomy here and then go back to the previous slide. So here, when you can see here, this is a lens. Okay, what you are seeing here is a lens. This is the suspensory ligament of the lens. So the lens is suspended by these ligaments. Okay, that's why these ligaments are called suspensory ligaments of the lens. And this is where your ciliary muscle is located. Okay, so this is the ciliary muscle. So this is a ciliary muscle and this is your iris, and the gap between the iris is what is called as pupil. Clear? So this iris will come closer, that's why it's called as constriction of pupil. So now here what you're seeing is the lens, the suspensory ligament of the lens. This is the ciliary muscle. Now, so when the eye focuses on a nearby object, what happens is the suspensory ligament will relax. Okay, now if you see the arrangement within the whole eyeball, if you see, this is the ciliary muscle. So ciliary muscle is a circular muscle like this. It's a ciliary muscle. So when the ciliary muscle contracts, what happens is it moves forward. Understanding this, when the ciliary muscle contracts, it comes closer to your iris. Okay, it moves like this. So the ciliary muscle is contracting. So when that happens, if you see, what exactly happens is, so when the ciliary muscle, so if you can see here, just this is the representational diagram. If you can see here, this is the ciliary muscle. So the ciliary muscle will be all around the eyeball. It's fully circling the eyeball, as you saw in the previous diagram. Okay, so when that muscle moves forward, what happens is this suspensory ligament, okay, which is attached to the ciliary muscle, relaxes. Okay, so now if you see here, see, this is a tensed lens, okay, which is like pulled on either side or all around by your suspensory ligament. It is like the suspensory ligament is tightly pulling the lens from all the directions, like 360-degree also it is pulling the lens and keeping it flat. Now when the suspensory ligament relaxes, what happens is the anterior curvature of the lens increases. Okay, posterior also slightly changes, but the anterior curvature is the change is more when compared to posterior lens. Okay, posterior side. So this is the relaxed suspensory ligament of the lens. So when the suspensory ligament relaxes, what happens is the anterior curvature of the lens increases. Why the suspensory ligament is relaxing? It is because the ciliary muscle contracts. So if you can see here, when the whole ciliary muscle, okay, contracts, when the ciliary muscle contracts, it will come forward, right? It will become like the ring becomes smaller ring. So when the whole ciliary muscle has come off front, what happens is now the suspensory ligament of the lens relaxes. That will cause increase in the anterior curvature of the lens. So now we'll see the slide here. At rest, what has happened is the suspensory ligament of the lens is tense. Okay, it will be under tension. So this suspensory ligament is attached to the lens, right? It is attached to the capsule of the lens actually. So the suspensory ligament will keep a traction on the capsule of the lens, and that causes flattening of the anterior surface of the lens. So when the eye gets accommodated to near vision, when a person is trying to see the near object, what happens is the ciliary muscle will contract now. This contraction of ciliary muscle causes relaxation of the suspensory ligament of the lens. So this normally now what has happened, the natural elasticity of the lens is to become more and more convex. So a more spherical shape of the lens provides additional bending of the light rays which is necessary to focus the nearby objects on the retina. So now when a person is trying to see a closer object, what happens is the power of the lens should increase. So the power increases when it becomes more convex. So now the three changes what we saw in accommodation is, first change is the convergence of the eyeball. The next change was constriction of the pupil. The third change is curvature of the lens increases. It is nothing but the anterior curvature of the lens increases, to be more specific. Okay, the anterior curvature increases. So you can remember it, the three changes what we see in accommodation are three C's. Okay, one is convergence of the eyeball, constriction of the pupil, curvature of the lens increases. So remember it as three C's. Three C's of accommodation. So now how exactly this increased curvature of the lens works is, increased curvature of the lens increases the power of the lens, and this helps in focusing the divergent rays of light from a nearby object onto the retina. So I told you the power of the lens has to increase when a person is trying to see the nearby object, because the nearby objects will give a diverging rays of light. So all this has to be focused onto the retina. So that is why this increase in curvature of the lens helps in focusing these divergent rays of light onto the retina. Coming on to constriction of the pupil, because this allows only the central part of the lens system to be used, and this will again sharpen the image or gives a clarity to the image. That's why the constriction of the pupil will reduce the amount of light entering, or it gives only the middle part of the lens will be used for sharpening the image. Convergence will bring the corresponding retinal point into focus. That's how the convergence will help in accommodation. Now, if you want to see the pathway of this accommodation reflex, if you see here, we all know the optic pathway, right? The visual pathway. So light falls onto the retina. From the retina, we know via optic nerve, optic chiasma, optic tract, lateral geniculate body, optic radiation. Finally, it goes to striate cortex. Striate cortex is nothing but your area number 17. So area number 17 in the visual cortex, the impulses are similar to a visual pathway. Now from here, remember, via superior longitudinal fasciculus, now the visual impulse will go to reach a frontal eye field area number 8. Remember, visual cortex is present in occipital lobe, but frontal eye field is present in the frontal lobe. So the information goes via superior longitudinal fasciculus to the frontal eye field, that is area number 8. From there, via corticonuclear fibers, these impulses reach the midbrain, that is your Eddinga-Westphal nucleus. Okay, this reaches the Eddinga-Westphal nucleus, and which is nothing but your oculomotor nerve nuclei. From there, via short ciliary ganglion, this goes and causes contraction of the pupil as well as the ciliary muscle contraction. So all this will increase it causes convergence, it causes constriction of pupil, and it increases the curvature of the lens. So just to summarize again now, the pathway of accommodation reflex, it is very similar to your visual pathway. Okay, your visual pathway. From the retina, the impulse has reached your occipital cortex, that is the posterior aspect of your brain. From there, via superior longitudinal fasciculus, now impulses will reach area number 8, and this area number 8 is present in the frontal lobe of your brain. From the frontal lobe, area number 8, frontal eye field, what happens? The impulses will come to brain stem now to your midbrain. In midbrain, we have Eddinga-Westphal nucleus, right? So impulses will come here. From Eddinga-Westphal nucleus, impulses will go via the third cranial nerve, oculomotor nerve, to your medial rectus, sphincter pupillae, and also to ciliary muscle. It will cause contraction of all these muscles. So that is how it brings about. Moving on to applied aspect. Ergil Robertson pupil and AD's pupil. Okay, so when we examine clinically, what happens is either patient will have what is called Ergil Robertson pupil or AD's pupil. Patient might have this is called light and near dissociation. See, whatever I'm talking till now here is nothing but near reflex, or nothing but you can call it as accommodation reflex. Light reflex, when you put a torch light, the pupil goes for constriction. That is your light reflex. But suddenly you bring an object from far distance to a near your eye, the changes what takes place, you call it as accommodation reflex. So that's a dissociation between light reflex and accommodation reflex in these two conditions. Coming on to Ergil Robertson pupil, it is characterized by bilateral constricted pupils. Okay, so here what happened is accommodation reflex is normal in these patients, but pupillary reflex is absent. So normally what happens when you throw a light, your pupil goes for constriction. But here what has happened, already the pupil is in a constricted position. Okay, so this feature is known as light and near dissociation. So pupillary reflex is absent. The patient's pupil is not responding to light. And this was first, this Argyll Robertson pupil was initially was described in neurosyphilis patients, but these days the cases of neurosyphilis is rare. Okay, it was described by a Scottish ophthalmologist, Douglas Moray Cooper Lamb Argyll Robertson. But you can also see these Argyll Robertson pupil in conditions like encephalitis, diabetic neuropathy, multiple sclerosis, or stroke patients sometimes. But pupils are very small or constricted, right? But it'll have an irregular margin here. Now, how to remember Argyll Robertson pupil or ARP is in these patients, ARP, accommodation reflex is present. Okay, remember their near response is present, accommodation reflex is present. But when you read it from reverse, PRA, nothing but pupillary reflex is absent. Pupillary reflex meaning it's a light reflex. So the light reflex is absent in this Argyll Robertson pupil subjects. Where is the lesion in these patients? Okay, now it occurs due to damage to the fibers. So if you can see here, now pretectal nucleus. Okay, pretectal nucleus is present in the midbrain, and this is what stimulates your Edinger-Westphal nucleus. Okay, this pretectal nucleus is also responsible for like if you can remember, this is a pretectal nucleus, and this pretectal nucleus has a, this is a rostral part, this is a caudal part. The rostral part is responsible for light reflex, and the caudal part is responsible for accommodation reflex. And what they tell us, in neurosyphilis, what happens is there's a damage to this uh, rostral part. So what happens? Light reflex is absent, but accommodation reflex is present. So the lesion is in the pretectal nucleus. So the another pupil, what you can see is AD syndrome, otherwise AD's pupil. Here, the pupil is tonically dilated. So in Argyll Robertson pupil, if you see in a resting condition, the patient's pupil is constricted by here, but here it is dilated. So when you put a torchlight, normally a dilated pupil, what should happen when you throw a light? It should go for constriction. But here it will go for constriction, but it is reacting very slowly. So very slowly, so they like you'll have a confusion whether he's responding or not, so that slowly the patient will be responding. But for accommodation reflex, a clear response is noted. What is accommodation again? Patient was seeing somewhere far, you suddenly asked him to focus on your finger or a nearby object, suddenly pupil is going for constriction. But when you throw a light, the pupil is responding very slowly. Again, this is again caused by damage to the postganglionic fibers of the parasympathetic innervation of the eye. Like nothing but your parasympathetic innervation is nothing but your third oculomotor nerve. Your Edinger-Westphal nucleus is what is affected here. The nucleus of the Edinger-Westphal nucleus is affected in your AD's pupil. But now hope you guys have understood. In Ergel-Robertson pupil, in a resting condition, the pupil is constricted. So when you throw light again, there's no further constriction. So the light reflex, the patient is not responding to light at all. But in AD's pupil, what happens is the patient in a resting condition, patient's pupil is dilated. Now when you throw a light onto this patient's eye now, he'll be responding, but it is very slow. Clear? But when you do this test for accommodation, immediately he'll respond. Immediately you can see convergence of eyeball, constriction of pupil, and your curvature of the lens increases, but not for the light. Again, in some patients, no, like the patients with raised intracranial tension, the light reflex will be sluggish. Okay, the reason behind this is the pupilloconstrictor zone in the pretectal nucleus, nothing but the pretectal nucleus, no, that is very close to aqueduct and third ventricle. Okay, so I think you guys know aqueduct of Sylvius connects your third ventricle to fourth ventricle, right? And that is where if there's any block, what happens is there's a raised intracranial tension. It's a very narrow tract which connects third ventricle to fourth ventricle. So now it's very, your pretectal nucleus, no, nothing but the pupillary constriction zone area in the pretectal nucleus is very close to aqueduct of Sylvius, and this being the common site of like lesion in raised intracranial tension patients, what happens is sometimes the light reflex becomes sluggish in these patients because this is highly sensitive to raised intracranial tension. I think for the like to understand the light reflex better, you can see another video which I've already uploaded. So light reflex and accommodation reflex always go hand in hand, okay? Because immediately for after doing the direct light reflex and indirect light reflex, accommodation reflex has to be tested. That will give a clear indication how the pupil is responding to light or to any object which is placed suddenly in front of your eyes. Thank you.